So we have just a little bit longer, a few more seconds. Panelists, I have muted you, but you are able to unmute yourself, just so you know. That way we can keep the sound down. So, Joanne, I unmuted you, Joanne.
Thank you. Just I have 12:59. Shall I go ahead?
Whenever. One minute, maybe. Yeah, we have 12:59 as well.
We're catching up here in Baltimore.
Yeah, that 1 minute time change is so crazy.
I am going to begin. Good afternoon and morning. Welcome to the NYMAC Transition Webinar Series. I am Joanne Bodertha, a medical geneticist and pediatrician in the Institute of Genetic Medicine at Johns Hopkins, and privileged to be co-director of NYMAC, the HRSA-funded regional genetics and newborn screening collaborative that includes Virginia, West Virginia, Maryland, Delaware, the District of Columbia, New Jersey, Pennsylvania, and New York. We are delighted to bring together several hundred participants from 42 states, 4 provinces of Canada and Australia to address successful transitions from parental care to self-care and from pediatric to adult care services. Thanks for joining the national conversation on transition. How do we ensure that the progress we have made together in family-centered care, education, survival, and inclusion of so many children with genetic conditions is sustained and allowed to flourish in adulthood? Our speakers were selected for their strengths and success in working with adolescents and young adults with special health care needs to make successful transitions. We are grateful to the NYMAC staff, Kathy Harris and Suzette Panaccio, who are on today's series with us for all their work. You have on the slide in front of you our speakers for today. This series will continue, as you know, over 7 more sessions. Renee Turchi, who is the director of the Pennsylvania Medical Home Program, will speak first on the key components of transition and how to find information. And then Kathy Hassel, professor of medicine hematology at the University of Colorado School of Medicine, and Bob Ostrander, who heads the Valley View Family Practice in New York State, will speak about age-inclusive specialty care centers and MedPeds and family medicine. Again, I am delighted that you are all on today. As you can see, questions are welcome through the chat box. We will allow 5 minutes for question and answers at the end of each of the talks, and look forward to your participation today and in the future sessions. Thanks so much.
Good afternoon. This is Renee Turchi, and I wanted to thank the folks at NYMAC for inviting me to give this talk today on key components of transition and how to find information. Delighted to be here. I have a number of slides, and I'm going to move through some of the screenshots fairly quickly. I just wanted attendees to have some of the resources that they could go back to, but I will be covering the information, but you'll see that some of what's in my slides is for you to have as a reference. So in thinking about addressing transition, which I think of as a cornerstone and sort of medical home and sort of how we are working with youth in our practice, I would be negligent if I didn't just mention that the triple aim. And I think that, you know, Don Berwick, for those of you who are familiar with the triple aim, you know, we're talking about better health for the population, better health care for individuals, in this case youth, and lower cost through improvement. And I think addressing transition in a formalized, structured way with tools and resources helps us to operationalize the triple aim as Dr. Berwick really conceived of it. So why is transition important? Why are we all on this webinar, and why are we thinking about this? Well, it's not just the 500,000 youth with special health care needs that are transitioning every year. It's really all adolescents who go from pediatric to adult-oriented systems. And As we know, there's 18 million adolescents in the age group of 18 to 21, and about a quarter of those adolescents have chronic conditions, and there's many more. And we often talk about how many typically developing youth may just transition with their immunization records or go to their parents or caregivers, adult health care provider. And that still is a transition. But certainly as we think about youth that may have multiple community partners, specialists, educational or vocational issues, waiver insurance issues, that transition process can be quite complex to navigate for youth and their families and caregivers. And many of our youth aren't prepared for this change. And we know from the literature that families and youth say the quality of care can be compromised. We know in certain populations, for example, in sickle cell, there's, at times there's disease entities where, diagnoses where sometimes we see care or increase in morbidity during the transition time, and that's all why we need to be thinking about this. We also know that from the healthcare provider perspective that there's report of having a lack of a systematic way and the structure and institutionalized approach to support this transition from pediatric to adulthood. So when we're thinking about what are we addressing and what should we be thinking about with transition, and there are many facets. It's beyond, obviously the healthcare is inordinately important, thinking about primary care and certainly all the specialists that are needed for our youth to transition. But certainly when we think about the medical home, it extends beyond just the medical system. So we have to think about education, we have to think about employment, we have to think about community living when it's relevant, self-advocacy, resources, and really doing all this in the context of being patient and family-centered. This is just a funny slide that I thought was kind of cute and relevant to transition. So we have the butterfly telling the police officer it's an old photo, a little caterpillar. I like humor, sorry. So one of the things that I wanted to discuss that is important as a resource and just kind of give you the highlights are the clinical report that came out that represented joint efforts from the American Academy of Pediatrics, Family Physicians, and American College of Physicians in 2011. Targets all youth starting at age 12, and there's an algorithm in that article that's just excellent that really talks about how you can approach youth with special health care needs and really is applicable to primary and specialty practices, which I think is very relevant to the audience here today. It extends through that transfer of care to adult medical homes and really highlights at various ages, what to do. So at age 12, for example, we have youth and family aware of a policy, which we'll touch on in a minute. And then at age 14, which is critical, that healthcare transition planning is initiated. At age 16, we're preparing youth and parents and caregivers for that adult approach. 18, we're transitioning to that adult approach to care. And then 18 to 22, we're transferring that care. So that kind of gives us the 30,000-foot view of what we're going to talk about today. And I wanted to highlight and thank my colleagues at the new GOT Transition National Center, which is the Maternal Child Health Bureau's grantee. I'm on their advisory board, and they also have been personal mentors to me, as well as sources of information on our own work in Pennsylvania in our medical home program. So they are Dr. Patience White and Pebby McManus are the co-directors, and you can see on the slide here the project team and consultants and executive team, and Dr. Mann is the project officer. So they have helped, and I'm going to highlight a lot of the information that is available through GOT Transition that I think will be really helpful to our audience here today. So when we think about the six core elements and sort of what in 2 slides I'll actually highlight what the 6 core elements we're talking about, but I wanted to just highlight that in GOT Transition these 6 core elements have been identified and discussed with Dr. Carl Cooley and Jeannie McAllister, who were the first grantees of the GOT Transition grant. And so what there's new 6 core elements. We call it 2.0. So what's new about those, and for those of you that may be familiar with the 6 core elements, one of the things that I just wanted to underscore to kind of frame the 6 core elements are that when we transition youth to adult healthcare providers, there's various scenarios where this is relevant. So it may be that in pediatric a scenario or a family medicine provider might be transitioning a child or youth in this case to an adult health care provider, an adult sector, so a med-peds provider is we have a youth going from one pediatric-centric model to an adult-oriented health system. But the other thing that is relevant is that within family medicine or medicine pediatrics, for example, we might have a youth that's not actually changing practices, but still is going through that developmental milestone of transition. And so that's an important, what we see there highlighted in the lavender. And then the third piece that the 6 core elements address that you'll see some of the resources highlight are the integrating young adults into adult care. So that's where, again, you're in that adult environment, whether it's internal medicine, family medicine, or med-peds, but you're integrating that young adult into those sectors. So those sort of 3 scenarios then inform these the 6 core elements of transition. And what I really wanted to highlight that I think are very tangible resources and approaches that you can sort of, what can I do in my office next Tuesday, kind of thinking about information and resources that folks can use. So these 6 core elements, what are we talking about? Identifying a transition and developing a policy, transition tracking and monitoring, looking at the youth's readiness and orientation into that adult practice, and then integration into the practice, and then the physical transfer of care to that adult approach in that initial visit, and then that transfer completion and that ongoing care that occurs within that adult arena. So there's samples and tools, and I just wanted to make sure you had in your slides the GOT Transition website where most of everything that I'm going to be presenting here today is available to you, but just to give you a flavor of what you might be able to access. Many of the tools are customizable using the Word version, and in my own social worker, my own practice, I just used some of these tools and modified them and found it inordinately helpful, and they're also available in Spanish. So the first sort of core element is that transition policy, and there's policies that are available in the 3 arenas that I mentioned, those 3 scenarios, and that emphasis on the adult approach to care and thinking about what happens legally at age 18 and looking at support decision-making, guardianship, those things, and really being very clear about ages in the policies. And one of the things we have here, actually I have 2 slides that kind of show you, I think it's very helpful on the GOT Transition website, some sample transition policies that you can look at. And it's, when you think about a typical medical home model, there's examples here for both pediatrics and adult practices to have their policy. And as Patients White often says, we post policies on, requesting referrals or, payment at the time of visit. So this is how we should sort of think about these policies. They should be transparent, readily available, and they really should be embraced by the practice entire team. Everyone should be aware of and inform what the policy is, agree upon it. And certainly in developing a policy, we want to include our youth and our family partners in helping inform what would work for our population and get feedback. Certainly, policies need to be culturally and linguistically sensitive as well. And, again, GOT Transition has sample policies that you can work from and then modify. Any problems here? There we go. Sorry about that. So the next sort of distinct sort of core element that I wanted to address was tracking and monitoring. Again, available in the 3 scenarios. And we really want to make sure that, using either a flow sheet or an Excel registry, that we are tracking our patients that actually do need to transition to adult-centered care. And so, many of our EHRs can do this functionality. There's also flow sheets that GOT Transition has available where you can sort of go through, what's available. There's sample registries that you can use if you're going to use an Excel spreadsheet or again use your EHR. But the whole idea is using a registry, which we know has been a very widely accepted tool to manage our patient populations and track who we are going to work with, what is the outcome of that specific patient and family, looking at diagnoses, maybe looking at complexity, and tracking appointments and when follow-up appointments are scheduled. And it just keeps us all within our practice aware of what next steps are. Our third core element is really looking at that orientation to the adult practice. And so thinking about some of the tools that are available is really, there's some great welcome and orientation materials that folks can use. There's part of our, for many of us that are in the pediatric sector, identifying adult healthcare providers that have the capacity and knowledge and willingness to take some of the youth that we're trying to transition is critically important. And, you know, identifying insurance issues and those kinds of things. So preparing our families for that, you know, transition process is important. So one of the, there's many different tools out there. There's some sample readiness assessment tools. This is just to give you an example of one that you can use from GOT Transition, where if it's applicable for a youth who could fill out some of this with their caregiver, or, you know, if not, there are other readiness assessments that might be done by a caregiver who, with the youth that might not have the cognitive ability to do this. But really the whole point is kind of thinking about, you know, identifying gaps and also thinking about areas of strength and really working on sort of self-management and identifying areas that we can help support that youth and their family. The fourth core element is transition planning and getting integrated in that adult practice. So updating the transfer package, and this is, I think, one of the critically important pieces in this arena is that template for the plan of care. That's where we have that medical summary, emergency care plan, really embracing care coordination, which is essential. We know medical home, but really is important in all systems, and it's a patient and family-centered, team-driven, based approach to care, to medical home and transition. And we know that in transition, care coordination across sectors is paramount. There's a new care coordination policy statement that came out by the American Academy of Pediatrics. If folks are interested, you can access that. And really in transition care planning, we want to think about how important this is for youth with special health care needs that are transitioning. We included here on this slide, you know, if you're using an EHR, you're developing your own care plan, some possible areas that you might want to address in that care plan. There's also sample care plans on the GOT Transition website that you can use. Again, they should be filled out with the youth and their family, and this is a great tangible tool to pass on to that adult practice. There's also emergency care plans and medical summaries that can be filled out and used, and again, these are modifiable. The other piece that is key in this arena is the condition fact sheet that's relevant for the youth who's transitioning. So we also, in transferring of care, sort of moving along in the continuum, we have a sample transfer letter and that transfer checklist. So here's a letter, you know, where you are giving to that adult care provider on the pediatric end, kind of summarizing some of the salient points. And with that, one would include a transition care plan. And again, you're looking at the self-care assessment, really looking at shared decision-making, looking at access to information, you know, and really looking at, across the adult sector, how the adult approach to care is relevant to transition, and looking at, you know, how we communicate, health literacy, compliance, and addressing that with the patient and families. So again, this is you know, that self-care assessment that on the adult side that we might want to be reviewing with the family or filling out. And again, all in moving that patient across the continuum. And then we get to the transfer completion, and that's where, you know, the youth is safely landed in that adult practice, but it's important, as we know, that we want to make sure that that transition actually occurred well, and that in our own quality improvement, we can assess how that went and where we can get better. So one of the nice things that I think GOT Transition affords you can develop your own or some feedback surveys for the families and the youth to talk a little bit about how that transfer occurred. And so there's several feedback surveys that you can access. And then there's also one of the important practice things that I think we're actually using this in the medical home program that I work in, is that before you launch actually some of your transition activities, and while you're doing it, there's a great needs assessment that GOT Transition has developed. It's a measurement tool that actually lets you take the temperature of your practice and see where you are on the continuum of these 6 areas that I've addressed today. See where you are, identify gaps, look at, you know, where you might want to start, where you want to address, and those measurements are 2 different tools available for both pediatrics and adults. So you can score those, and it really can inform your next steps in the transition process. So I've highlighted there just the, you know, examples of how one might fill it out, and you can certainly access these tools on the GOT Transition website. So these are all just, you know, opportunities for you to really move yourself along the continuum, and as a team, fill that out and really make a plan for your own practice's approach to transition. In closing, I just wanted to show you a couple of screenshots from the Got Transition website, so absolutely go on there and get some of these resources and tools packaged beautifully. And I would just say, as my last slide before I open up for questions, that there are lots of resources out there. There's definitely hope. While transition can be a bit daunting for providers, patients, and families, I think there's a lot out there, and we need to address this head on. Looking at adopting a policy, looking at some of the readiness tools, and thinking about encouraging our youth to maximize their potential with recreation, employment, looking at the care plans, thinking about the school issues, and again, I think the reason why all of us are on this webinar today is that we want to make sure that at the cornerstone of this are families and youth, and making sure that we assist them and that help them learning about their resources and then support their engagement in this process, no matter where we are. So thank you. I have my contact information on my slides if anyone has any questions. And again, I know I've had a lot of screenshots of tools. I apologize for going quickly, but I really wanted to give you guys a flavor for what was available. So thank you very much. I'm happy to take questions at this time.
So it looks like there are not any questions at the current moment. We are 2 minutes ahead of schedule. If anyone does have a question, they can type it into chat and send it within the next few seconds. Otherwise, we will go ahead and move on. Thank you, Renee. That was very wonderful. And just so the attendees know, any information you would like that's from these webinars, you can email us, and we will give you as much information as possible. All right. Thank you, Renee.
Thank you.
Since there are no questions, you're very welcome. Thank you. Since there are no questions, shall we move on? I will give control to Kathy Hassel.
And can you take me off mute as well?
You're off mute.
Okay, very good. So I hope everyone can hear me. Thank you very much to NYMAC and the organizers for this very, I think, important series of webinars to talk about things that are of interest for both pediatric and adult providers and the providers who span the life and the care of individuals. I got a 10-second delay here. The next slide that's going to come up is about disclosures. I think I don't have any financial disclosures, any academic conflicts, but I do want to declare that I'm an adult provider, and in 20 years of working with sickle cell patients as a hematologist, I've heard that I don't exist, and if I exist, I give really bad care such that the youth die once they come into my care. And I think neither of those things is true. And I think across this country there are adult providers who are engaged or willing to be engaged in the care of youth with even complex disorders. And so my goal in engaging this area of work over these last years has been to give a voice to the adult provider and to the youth who come into my care in order to have a more robust and supportive system for individuals, especially those challenged with chronic conditions. The point I'd like to make and emphasize on Renee's part, I have a long delay on my slides, my apologies, is that she made a point, and I want to emphasize the distinction between transition and transfer. As she very nicely characterized and as God Transition focuses upon, transition is a process that we all go through. It's something that happens when we go from childhood into adulthood. And this is going to take place regardless of which clinic door you walk through at age 18 or at 20. And so transition, for example, does not culminate with successfully arriving at the adult clinic at age 19. That is, I would argue, midpoint in a transition process. And I think the opportunity of my presentation today is to look at a couple of specialty care settings in which there has been organization around transition, at least in the realm of specialty care, because I think it's going to reveal important issues that go far beyond the mechanics of transferring a person from one part of the healthcare system to another. And so, for example, as the point was made already, even at a children's hospital, once you turn 18, you now become, as the individual, the person responsible for point of contact, source of consent. You can't call Child Protective Services if that 19-year-old doesn't appear to be taking good care of themselves unless you choose to declare them incompetent or vulnerable as an adult, something with many downstream implications. So regardless of the setting of care, the process of transition needs to continue. And the next are just a couple of screenshots as they come up as regards the things that you should be asked to sign when you turn 18, even at the Children's Hospital. I voluntary consent. I authorize. I agree to be responsible for copays. And so arguably this is a process, regardless of setting, that youth will face, even if their transfer of care doesn't come until a later point of time. And I'd point out that this is potentially an empowering step, even at the Children's Hospital or in the adult hospital, where and Suzanne, I'm having a lot of trouble with the slides here, but where it talks about you have the right to be informed as your new independent adult, but also, let me point out, to have family members involved in your care. And often the adult system is seen as not incorporating the family. You can only talk to the youth, and what if the youth isn't able or empowered or have the capacity? In the adult world of medical care, we are quite accustomed to engaging and involving parents, children in the case of elder care. We aren't exclusive. It's just that the locus of control now falls to the youth who is legally of age. So I'll just point out the definition as Renee characterized it in consensus statements now some 10 years old. We go from child-centered to adult-oriented and adult-focused care, not necessarily a transfer in a physical place where that care is given. So with that in mind, let's look at the experience that's taken place in models of specialty transition, and admittedly focused on specialty care as opposed to the primary care setting. And let's look at a couple of examples. One is cystic fibrosis, where, as those who are familiar, there is a whole entire system of cystic fibrosis foundation accredited programs. And then, of course, with hemophilia, where there's an entire network of care around hemophilia treatment centers. So for cystic fibrosis, the slide you see displayed, this is a disease characterized by an abnormality in salt and water transport and pertinent to care of individuals on a lifelong basis. Daily pulmonary care should be fastidiously adhered to. Enzymatic replacement to maintain nutrition for appropriate digestion, and fastidious control to fastidious attention to infection control, because all these things, if not done well, can lead to certainly foreshortening of life. On the next slide, as you'll see, the Cystic Fibrosis Association recognized in 1996 that kids were going to live, even born in that decade, into their 40s, and they only had 15 accredited adult programs, and so they declared a mandate that they would expect for their accredited programs across the country that patients would be seen by adult providers by the age of 21, at least 90% of the time, that this applied to centers with a preponderance, with a core set of adults of at least numbered 40, that accreditation for your participation in this network was contingent on planning transition. And in turn, as the CF Foundation can do for other activities, resources would be applied to recruit and support adult providers. They recognize the need. And on the next slide, you'll see just some models, and I'm not going to reiterate, but let me emphasize, you can receive adult-oriented care from your pediatric specialist as long as the care was adult-oriented, sometimes relying on an adult primary care provider to provide the more adult non-CF related care. So all sorts of models were permitted as long as a transition process was underway and adult orientation was taken to care when people became of age. And on the next slide is simply just a model or an example of the sorts of things you're going to hear about over and over again as we talk through the next week of this series. So how does that look on the next slide 10 years later with the cystic fibrosis? So it turns out in this country 85% of people with cystic fibrosis, youth and adults and children, are seen in accredited centers. There are now over 90 accredited adult programs. And when they surveyed 195 of these centers, they heard back from 170 centers, some of which were adult only, some of which were pediatric, and some of which were both. And when they asked them, what do you think about this now, 10, now 20-year-long dedication to transition, 80% agreed or strongly agreed, although 21% of those who provided both pediatric and adult care disagreed that this was important. And I don't know what that means, but I pointed out just because I think it's interesting. On the next slide, you'll see that 10 years after this mandate and the development of adult programs, about 60% of the centers involved the family and discussed this process. But only 20% or less had skills programs to foster skills in transition if they even assessed in the first place the readiness for this transition across the spectrum of healthcare from pediatric to adult-oriented. And on the next slide, you'll see some additional details. They talk about how transition is discussed at team meetings more than 80% of the time, but less than 30% of the time that they involve adult care providers in that planning. Did they prepare a written summary, as you heard Renee endorse? 46% of the programs rarely or never prepared that written summary. Primary care providers were known to the pediatric programs and even to the adult programs, and they usually always had a PCP involved, but only 2/3 of the time did they let the PCP know that the specialty care was going to be shifted. And in aggregate, at least at that point when published in 2008, the median age of transfer was 19 years, but the discussion about this entire transition process did not begin until the age of 17. So on the next slide, let's look at this, but does that really matter? Does it really make a difference in cystic fibrosis? So they saw it in looking at the registry that they have to see what the difference was for the setting of care, or an adult-oriented versus pediatric-oriented setting of care. And so the first line that you can see depicted on the table is the most severe form of the genotype was not over or underrepresented in either setting. People say, well, of course they did better in the adult system because only the well kids went on. Or, of course, only the sick kids went on, and that's why they did more poorly in the adult setting. In fact, they were evenly distributed. Highlighted in green on this table demonstrates that there was consistent benefit to being in the adult-oriented system over the pediatric-oriented system. That is, those who transferred had better outcomes than those who did not transfer, as would be recommended by the mandate. So if you look at the next slide, you'll see they said, well, but let's really look back and do a very carefully matched cohort that really propensity matched for badness that can happen clinically. There's a lot of clinical parameters. It can be a heterogeneous disease. And so they had 661 patients who at age 18 to 25 had transferred to an adult care setting, and 661 matched for all these parameters who did not transfer. And on the next slide, what you will see is that consistent with that initial look at the data I just showed you, that consistently the 18 to 25-year-olds matched for severity of disease did better in an adult setting or an adult-oriented setting. There was no increased rate in hospitalization. There were no increased use of IV antibiotics or loss of body mass index as a sign of poor nutrition. So in fact, at least in this admittedly closed system with admittedly supported specialty care, perhaps these young people did better in an adult-oriented system. So if you go to the next slide, let's see what people thought about this. So the adolescents and youth thought the formal process for transition when they had it was useful. And they really weren't so worried about more disease-specific information as they were about trying to figure out how to make the system work for them. On the other hand, their parents thought they needed more education about the disease-specific information. And what was, I think, most revealing in this survey was that the providers were afraid on behalf of their patients, far in excess of what the actual youth and young adults had in terms of fear. That is to say, providers were more afraid than the actual individual facing a transition or transfer, and that the youth who expressed fear did so because their provider told them to be afraid. Now, I put that in sort of forceful, active language. These are only correlations, but the youth who were less comfortable with transition had providers who were equally or more uncomfortable with that transfer or transition process. So on the next slide, it is possible, if you're not going to transfer a person, to just take that on as a pediatric provider. Let's attend to the transition needs of these young people. And so this was just a look at what happens to individuals who don't transfer. I don't really mind if my pediatric colleagues keeps the 22-year-olds, the 20-year-olds, the 25-year-olds, or even 30-year-olds, as long as they're attending to the need to transition to a sense of responsibility and management of your own health care in the setting of your family unit if that's what needs to happen. And so as you can see from the registry data, of over 3,000 patients who are aged 18 to 25, so far, only 1/3 of them actually made the transfer as, quote, mandated by the CF Foundation. And this is true despite the fact that they had accredited adult programs, accredited specialists, arguably recruited because they were trusted to provide the very care that would be needed in young adults. And so, but okay, they stayed in the pediatric system. Were they getting what they needed? On the next slide, I would argue that perhaps not as much as we'd like. They were on the pediatric side being taught to list their meds, to do respiratory care, to identify emergencies, but they weren't being taught in the pediatric setting, even though they're responsible for their own insurance now and copays, to know what the benefits were, to how to contact the insurer, how to designate the staff that can best help them. And if there was a deficit, there were no skills programs available in more than about 15% of these programs to enable the youth, even at the children's setting, to take on adult responsibility. So even though the transfer did not take place, it's not clear to me that actually the system in the pediatric world in this enclosed, supported setting was attending to the actual needs of transition independent of transfer. So on the next slide, does transition occur in CF? Some, for sure, but there is limited efforts to formally give skills assessment and to enhance management, all the things that you heard Renee talk about, independent of where the setting is being done. And there was infrequent discussion of adult issues, including sexuality, employment, reproductive discussion, per the survey that was done. So I worry sometimes we can get hung up on the transfer piece without attending to what is really needed, which is the broader transition piece, regardless of the care setting. And so just to conclude in the first few minutes, let's look at hemophilia. A severe X-linked disease, there's pertinent medical issues across the lifespan, including recognize what you should do if you have a bleeding episode. And increasingly, there's the use of prophylactic factor therapy. And the hemophilia system would tell you that by the time you're 12, you should be able to hit a vein, mix up your factor, and self-infuse. So there's an early attention to self-management and responsibility for your own health care in the world of hemophilia. On the next slide, you can see that about 75% of the patients in the U.S. are treated in this organized system of hemophilia treatment centers. There's about 130 centers that are connected through a universal data collection, and about half the population are adults and half the population are kids. And they have some discussion about models of care. Often they're university-based. Often for specialty care, they stay at a university-based sort of pediatric center if there's no adult program available. And there is an observation that if you go outside this network of specialty care, whether in pediatrics or adults, health outcomes are worse. And many of us on the phone would recognize that in the really complicated and somewhat less common conditions of which we think. So on the next slide, little has been done actually about evaluating transition in hemophilia. But what is discussed in this literature, again, in an organized system where there's access to care, is that children's hospitals are not designed to take care of 40-year-olds. Certainly the orthopedist who's operating on kids who need joint replacements or other things that are being done in the pediatric setting are not geared to take care of the 35-year-old person who needs a hip or a knee replacement or some surgery on a badly affected joint from hemophilia. And so there's a recognition that, especially in hemophilia, one needs to transition to the support that can be rendered in the adult system. And they talk about the concern in the hemophilia centers about a lack of emphasis on responsibility for independent management of the condition. And the final piece that I could find in the realm of hemophilia, because there's not as much data as in cystic fibrosis, is there was a survey from the Netherlands that looked at pediatric centers and they looked at 15 people who had not yet transitioned, 14 who had to, and then compared across that as they went through the transfer process. And they looked at 3 tools. They looked at apparently the John Hopkins Adult CF Program Survey that addresses the worries about transition. They applied pre- and post-transfer to these individuals with hemophilia. They looked at a health-related quality of life that's specific to hemophilia, and they looked at a questionnaire that applied to parents, and how stressed are the parents, and how much do they perceive their youth is distressed by the parents. And what it revealed is that the parents were far more worried and perceived there was distress in the illness in their child than the patient themselves endorsed. The patients were least worried about transition. From their perspective, there was no loss in quality of life. So it simply speaks to the potential context and influence that both providers and parents can have. So On the next slide, let me just sum up and finish by giving you my sense of what I learned by looking at these specialty settings where there are systems set up. So when there's a system set up, arguably maybe not the real world that many of you live in, but even when there's a system set up where CF says not only will we resource an adult center, but you should transfer, it still doesn't always happen. And it highlights the need that if you're not going to move and transfer settings, that attention to transition still needs to take place regardless of whether or not it's an adult provider or now an adult-oriented pediatric system. And I think it is an opportunity to explore what works. We get so hung up sometimes on, well, I can't find a doc, Medicaid won't pay. They're not going to pay your pediatric hospital either if it's an issue of being a legal age of 18. And there's a much bigger context here. And if we can take the time to step away from the transfer issues and look at the overall transition issues, I would argue that a youth ready to transition is going to be much more able to facilitate the transfer that often we perceive as the barrier. And with that, I'll go ahead and stop and see if there's any questions in the chat room here. All right. And I don't see any. Let me see.
I don't see any either.
Okay.
Again, if anyone has any questions that they think of later, you can always email us, and we can get you those answers. But it looks as if we don't have any at this time. Thank you, Kathy. Do you have anything else to add at the end?
Oh, I don't. And thank you, everyone, for your attention. I see a bunch of questions, actually, and I'm not sure to whom they're addressed, but we can certainly go through, as Suzette said, and collate them and answer questions, or at the end if Bob happens to finish a bit early. Thank you all.
Yes, we will be able to address those questions by email. Thank you. All right. Make sure that Bob is available and audio is open.
Still muted. There we go. Okay.
There you go.
Everybody can hear me? Okay.
Yes.
Good. Hi, I'm Dr. Bob Ostrander. I'm in private practice in a small rural family practice in upstate New York. I got involved with medical home and special needs issues several years ago when I was part of an initial NYMAC learning collaborative. And from there, started working with NYMAC and National Collaborating Centers. I also teach in the Rural Scholars Track at Upstate in Syracuse. My perspective on this is that of someone who is in a regular primary care practice where perhaps youth with special needs are a minority, and we've had to come up with some practical approaches to dealing with transitions, and I'd like to share some of that with you. Okay, there we go. And I've got a delay too. Get back there. Somebody advancing these for me or no? What's happening? I'm sorry.
Somehow it's not allowing you to do it. I wonder if your mouse...
Yeah, can you go back to the picture?
Sure, there you go.
Okay,
Try using your mouse instead as well.
I will. I'll try that. All right. Well, I guess this is my office in the middle of the Finger Lakes on a rainbowy day. So I want to start with, and I'm not moving again. I'll just tell you. There we go. I want to start talking about medical home for a minute because that really is one of the barriers to making things happen nowadays. What happened is that the NCQA kind of co-opted the pediatric notion of medical home for special needs children and changed the flavor of it a lot. So if you look at the literature on medical home now and the criteria that are being measured by various governmental and insurance agencies, especially for adult practices, you get a very different flavor from what was originally meant by medical home for youth with special health care needs. The NCQA model is largely driven by, I think, the part of the triple aim, the parts that involve population management and lower cost. So they focus a lot on chronic middle-age diseases that are common, and a lot on population management, and much less on personalized care plans. And so if practices get focused on the NCQA model, the special needs youth and children, I think, get left out in the cold a lot, and unfortunately the payment follows the other model. So until that changes, some of this has to be done just because it's the right thing to do. Next slide. I'm a lumper, not a splitter, so a lot of this Renee talked about, but I'm going to give you a more lumped version. The key components of medical home, in my opinion, are care coordination across the various domains: medical providers, support services, and then school, college, work, and of course in the family setting. Care plans are hugely important, and probably no more important than for the youth who's transitioning, because that kind of becomes the anchor. Everybody with special needs needs a portable medical summary, and we'll talk about that in a minute, a roadmap of what's the care will be in the short haul, and then emergency and acute action plans. The partnership with patient and parent cannot be overemphasized. One of the things that I found as I was putting this into practice is that it was very liberating, frankly, to think of my patients and their parents as partners, especially in this transition process. One of the best things I ever did was feel free and permitted to delegate responsibility of some of this to families. It can be difficult. Sometimes it has to be done firmly. Some parents are very proactive with their kids, and other parents and special needs patients, really across the age spectrum, have, for whatever reason, developed a feeling that they're entitled to have somebody else take care of it for them, and that can be an uphill battle, but it needs to be addressed forcefully and head-on. The last thing I'm going to mention about just the medical home concept in general is its benefits for quality of life, not with the medical illness. I mean, we just saw a lot of data on medical outcomes, but many of the endeavors that I'm involved with have involved and included parent partners and parent advocates. And one of the things that we hear over and over again is how having a medical home and having a care plan in place and having a roadmap in place allows them not to worry on their good days. So much energy and so much loss of quality of life is spent with anticipatory dread of something going poorly, that knowing that there's a plan and knowing who to call allows folks to relax and enjoy their good days. Next slide, please. So a little touch on each of these things, and again, they're medical home in general, but they're real important for transition. So the portable medical summary should include diagnoses, the dates, key events and procedures, so any surgeries, any big hospitalizations, medications and allergies, names and contact information of the primary care provider, consultants, and the family contacts. This needs to be in a form that's utilizable. Early on, we had some notions that producing applications and thumb drives for this might be a great idea, but with heightened internet technology, a lot of those can't be opened, at least not hospital system. The portable medical summary should be in the medical home and, most importantly, be with the patient and their family. Depending on how involved it is, all or part of it may be shared with consultants. Next slide. So here is sort of a sample of a roadmap of actually a patient of mine. You'll notice that it's pretty simple, and I think that's somewhat important. And one of the downfalls of some of the tools you might find online are that I think they're built by committees. And when things get built by committees, everybody has a thought about what shouldn't be left out, and pretty soon they get really complicated. So, I would encourage people to, follow the keep it simple approach. So basically, one way to do this care plan roadmap is for each of the problems, and you'll notice that for this particular patient, we're talking about her PKU. And her asthma, and her wellness and prevention and transition. You need to, for each of the problems, there are certain things that have to be done on a regular basis, and the task and the schedule, and most importantly, I think, is delineating the responsibility so that the consultant specialist doesn't think that the primary care doctor is doing it, and the primary care doctor at the same time doesn't think the specialist is doing it, so it doesn't get done, or on the other hand it gets duplicated. So I think that's important, and that very much needs to be shared with the consultants. You notice that I had the reproductive piece at around age 14, and transition should be on everybody's roadmap, along with the wellness and prevention issues. Next slide, please. Did we go past one or no? Yes.
I believe so. This one?
Okay. Yep, that's fine, I guess. Well, actually, go back one more because we're way down in the transitions care plan. There we go. So this is a sample transitions care plan, and again, kind of adapted from some that you might get online just because I wanted it simple. So as a sort of sub-care plan under the big care plan, I have a transitions one, and I share this early on with patients and parents, and it has the same kind of timelines that you might have seen in the other discussions and other slides. And I've set it up so that there's a column on the right where I or the parent or the patient can fill in whether the task is not started, where we are with it, or if it's completed. And again, just briefly, as similar to the previous ones, introducing transition should happen around age 12, and that may be modified. That probably should be the same for everyone. Review the special need with the child at 12 to 13, and for certain conditions, obviously, that may be a little too soon. And then there are very specific comments about the patient keeping a copy of the portable summary, and not just the parents, and so on. It's important, I think, to have on that list some of the non-medical things, and you see a lot of this is like that. Sexuality and reproduction is very important to these patients, and I think unfortunately often gets overlooked. The two concerns that they often have are, will I be able to have a normal sexual relationship and sex function, and also how will this affect both having children and what's the likelihood that my condition is going to be passed on to my children. Early on discussion of vocational interests, and that's something that even kids without special needs should be probably having that discussion around age 15. Thinking about adult hobbies and interests, I think that gets left out a lot, and so I made sure that that was on my list. And then the medical care provider ones are there. Around 15 to 16, already start thinking about those social things that Kathy talked about, what living expenses might be like, what living situation might be like, and I'll leave the others to you guys to read. Next slide. As we're moving down the road here, we're talking about some of it, the handoff. We're talking about finances and social services. Transportation, you can't overlook that. And another thing that, again, sometimes doesn't get included on these, but is very important for the college-bound student is what the college health system is like and what resources might be available in the college community they're headed to, both in terms of the college health system and also specialty care for their condition, and what's the nearest medical center and so on, and coordinating between two specialty centers. Next slide. A brief comment on the EHR. I really think it's a double-edged sword. We haven't entirely incorporated this process into ours because it's frankly been clumsier. We can produce the template, but I have not had it auto-populate. One of the good things is that information can be shared rapidly, and that you can design these tools that can pull in the information and highlight areas of deficiency and so on. But big problems. EMRs are often in flux. I don't know about you guys, EMR, but we get an upgrade, it seems like, about every other month. And that's an issue. They don't necessarily talk to each other very well. Probably the biggest problem, in my opinion, is the too much information problem. And I know everybody sees this with every interaction. The easiest thing to do now is to push a button and push everything to whoever you're allegedly coordinating with without filtering it for them ahead of time. And sometimes the quality indexes require that you include certain things, and the best way to make sure that you don't get penalized for leaving things out is to push everything, because there are no penalties for pushing everything. It is everyone's responsibility to filter, sort, and prioritize before they share information, in my opinion. Everybody wanting to use their own tools. It's easier for me to use my tool to send information. It's easier for the consultant if the information comes on their template, and so that can cause some headbutting at the very least. Mandates are a problem because, again, we in primary care with adults, at least, or mixed practices, are forced, in order to get optimize our payment, to focus on the NCQA medical home, which is very much chronic disease management. It takes a lot of time and effort and staff, especially in a small private practice, and there are just not enough hours in the day, and so the things that aren't rewarded by the system often get left behind. We talked about the security issue before. Next slide. And those are some references, just a couple little articles. Next slide. And thank you. My one closing comment is that, it goes back to the NCQA thing again. If you search the literature for information on transition, that also is changed. I mean, there are lots of transitions in healthcare, and the system at large now is focusing more on the transition in and out of the hospital for community hospital for adults, again, with sort of chronic diseases, because that's where the greatest number of problems are and the greatest number of dollars are wasted. So you have to be, again, a little careful, because if you look at medical home and transitions in a broad way, you're probably not going to get the focus information that's going to help us with our particular problem. Thanks. Right on time.
Thank you, Bob. Yes, wonderful. We were looking for questions in the chat boxes, but we have them in the questions area. So we'll go ahead and let Bob, since you just finished, we will let you look at the questions. If you can open the question box.
Hi, it's not very big. I don't know how to make it bigger.
You can double-click on the little box in the top right, not the X, but the one next to it. That will make them larger.
Suppress row display. What should I check on the suppress row display question? Michelle, Veronica.
There should be some assigned to you.
Yeah, they are. There's lots of names, and I got to ask her now.
So you can just verbally pick one or two and answer.
I can't read them, though. Is my problem. You better jump to somebody else, because I'm wasting your time here.
How is the issue of consent handled for special needs members that may not be able to manage their own health care needs for mental or physical reasons?
Well, that's part of transition, and in the care plan I have an area to discuss that before the age of consent. There actually is a great talk later on in this series on that very issue. Traditionally, lawyers will suggest that parents get guardianship, but that basically takes away it transfers the right of consent from the youth to the parent. And the shared decision-making and shared consent are more nuanced things. There can be so it needs to be discussed before the age of consent, and then it's a conclusion that hopefully all three folks reach together, discussing whether you want to do shared decision-making or guardianship. Power of attorney can allow both the patient and the a parent in the absence of or the deferral of the youth allow either one to consent.
But Bob, this is Renee. Just to add to that, there are cases, correct, where you might have youth that are completely nonverbal or have cognitive limitations where guardianship would be appropriate.
Oh, absolutely. But you just
Right.
need to know the whole menu, yes. I mean,
Exactly.
not very many cases need guardianship.
Right.
But that basically just under the law, I mean, infant is the word under the law of no competence. But, yeah, you can prolong their infant status indefinitely with guardianship. And should in those cases, obviously. That's a
Right.
parent-patient doctor decision.
Thank you. Why don't we go ahead and ask Renee a question? We have some here. Renee, have you had a chance to look at any of the questions assigned to you?
No, can you read one, please?
Sure. Do you have any resources related to transitions in inpatient medicine related to complex children?
Yes, actually there are. So I assume that question is referring to the transfer of care that sometimes is referred to transition of care. And they're actually going to be happy to get those resources out through NYMAC. There's a couple things that come to mind. One is Dr. Antonelli, who is a pioneer in care coordination, actually has a transfer of care tool. There's actually codes that you can actually bill for transition of care, depending, and there's very specific requirements about how that can occur and how quickly you have to see the child or youth leaving the hospital, and then when you bill for that. And there is also a transition of care, sort of care plan bolstering tool that I also have. So I'd be happy to share those. And I think that that's a really important question. It's a big focus right now, on obviously improving quality of care and reducing hospital costs. So I'm happy to share those resources electronically.
Wonderful, yes. And again, to our attendees, if you do have any questions or want anything else, please feel free to email us. We have all the questions that have been submitted during this webinar, and we will try to address those by email as well. NYMAC is here to help providers and consumers, so you can email us for more resources at any time. Thank you, Renee. And one question for Kathy Hassel.
Go ahead and pick one there, Suzette. You're doing a great
Okay. All right, well, it looks like here, what process have you found to be most successful for identifying adult primary care physicians who are interested in caring for children and youth with special health care needs?
It's a complicated issue, and it's highly variable depending upon your healthcare setting, region of the country, that sort of thing. I think sometimes it starts in the adult side with as simple as I have individuals with special health care needs who have adult primary care providers, and I look to see if they'll take more, if they've already had an individual with, and it may not be sickle cell in my case, but some other special health care need. Academic universities are not always the best place. Sometimes nurse practitioners, community practitioners, family medicine are actually eager to adopt in a collaborative practice manner individuals with complex healthcare needs, understanding the specialist will be there to support them through some of the specialty challenges. In some cases, I'll ask the mom, yep, I let parents in the room with the adult child as long as the adult child's okay with it. Where do you go for health care? Would your provider be interested in also caring for your now adult child? I think many people do receive health care. It's more a matter of recognizing and identifying those who are willing to, and it's a one-by-one thing, especially in rare diseases, but certainly even in less rare conditions like sickle cell. It's recognizing practices that are able and willing to be supported in the primary care setting around individuals with specialty needs, recognizing that there's a co-management that can take place that can be very successful. The short answer is there's no magic, and I do think it's going to take place within an area where you practice on an almost one-by-one basis and identifying individuals who have, if not the capacity, the willingness to gain the capacity to work with individuals with special needs.
Wonderful, thank you.
So Kathy, the rest of the speakers, this is Kathy Harris. You still have a little more time. We still have people on if you want to answer a couple more questions. Does that work for you, Kathy, Bob, Renee?
Sure, for me, for sure.
got
Kathy, one came.
a couple more
Yeah,
minutes.
go ahead, Bob. A couple more minutes, fine. Let me ask something that came where is it? There it is. For Kathy specifically, please add a bit about your work transferring the population with sickle cell disease in Colorado.
Sure, and let me just say, in this series, Peter Gillette, who works in New York, is going to give an adult, sickle cell-based presentation with a bit of an adult perspective as well. So I don't want to steal any of his thunder. Specifically here in Colorado, youth do not need to leave the Children's Hospital. Technically, I think it's age 26. They'll take they'll take young people with cancers that are childhood in etiology most usually. You can go to Children's Hospital at age 25 with a new cancer if it's considered a pediatric cancer. So they applied that more broadly. What I would say is we've attempted here to coordinate between adult and pediatrics to make the transfer of care take place when the individual feels like they have transitioned in other parts of their life sufficiently to manage going 2 blocks down the street to a different institution than they're accustomed to. This has been a growing and learning process for our pediatric hospital, however, and together we try to reinforce the notion at the Children's Hospital that the 19-year-old cannot be coerced to come because you called the mom to say he didn't show up, and or we try to encourage them that the appropriate legal paperwork is completed for someone still attending the Children's Hospital. And we do try to foster communication between the two aspects of the program since they're physically 2 blocks apart and distinct versus being done in a single center. So we are flexible about when a transfer of care takes place, even as we continue to try to develop processes through a coordinator that works on both sides of the care continuum to build skills of transition across all elements, as Renee nicely outlined, not just when are you going to transfer the address to which you go for your hydroxyurea appointment. So we try to take it far beyond the transfer issue.
Wonderful. Thank you very much. Presenters, have you seen any questions that you wanted to address that's jumped out at you? All right. Let's see. I see one here. There's much on physical health. Renee, maybe you could talk about this. What about the behavioral health and maternity assessments and or tools? Do you know anything about that to share?
I'm not as familiar with the maternity assessments except to, as they refer or relate more to infants, for women who would deliver premature babies or have involvement in the NICU where that transfer of care occurs for an infant who's born with a special health training and spend some time in the NICU. So I'm not as, it would make sense for sure, and I imagine that some of those resources possibly may exist. Absolutely, I think that in terms of the mental health piece, I think that there's absolutely a growing body of literature and lots of folks that are doing work around the integration and co-location of the medical and physical health site. And even one of the things I was recently in a meeting out here in Philadelphia with some mental health providers who were talking about this issue that I think is quite interesting and appropriate, that for certain patients it may make perfect sense for the hub to be where we always think about sort of the medical the mental health providers coming to the medical arena. Well, we could also think about it for certain patients where the medical providers go to the mental health provider and they're co-located on the mental health side. And I think the point is that it's really about providing, as Bob was talking about, the medical home that's most appropriate for the patient, but where there's integration and transition is addressed in that that sector as well, and just the communication and a lot of the things we talked about in terms of care coordination. I think that the issues with mental health, certainly around consent, a lot of the things that we outlined, are very relevant, and so there are some there are some organizations that, like NAMI, and there's certainly diagnosis-specific transition-related materials like related to autism, but there's certainly some more global mental health organizations that have some. Certainly send some of the links that I'm aware of, but I'm certainly not an expert in the mental health field.
Hi, I just want to chime in on one thing. This is Bob Ostrader again before I have to go. The American College of Medical Genetics webpage has a link to what we call our ACT sheets. And we have developed transition ACT sheets which have some very basic information for a number of genetic conditions. So if folks are interested in resources along those lines, go to the ACMG, or American College of Medical Genetics webpage, and click on ACT sheets and then transition ACT sheets. We've tried, as we built those, to put in both the medical issues that might be important for transition and for the adult provider that's picking up, as well as some of the psychosocial and psychosexual and reproductive issues.
Wonderful. Thank you very much. All right. We
I have to
are at
dash.
about... Yes, you do. Thank you so much, Bob. Thank you to Kathy Hassel. Thank you to Renee Turchi and Joanne Badertha for attending to these and sharing your information with us. And thank you to all our attendees that joined us. Again, we will be answering questions by email, so if you want to type them into chat questions right now or email us, that's just fine. And please attend to the next session. We look forward to seeing you there. Thank you, everyone.
Thank you.
Thanks.
I just got
You hear me? No? Yeah?